After getting this discussion and lecture delivered by Professor Boren Chakraborty, everyone we know that primary PCI is the best option for STEMI. There is no doubt, and there should not be any debate on this. The primary PCI is the best option, and the best option should be offered for everybody, including Bangladesh. Why not for every person in Bangladesh? Anyway, I have to say something to complete my lecture. And in 1983, the first primary angioplasty done by Dr. Jeffrey Hasler, and he did 41 primary angioplasty in a very early stage. And he concluded that primary PCI is, without thrombolytic therapy, may reduce the likelihood of re-occlusion. And there was a long journey, 1993 to this time, 30-year journey. And there are many evolution, many changes of technique, pharmacology, and organization. So organization changes include call center, primary PCI within 120 minutes, 24/7 cath lab availability, regional networks, and transfer policy. Pharmacological evolution includes superior primary PCI superior to lytic therapy, potent antiplatelet drugs, and lipid-lowering agents, and simplified protocols. And PCI technique-wise, radial access, drug-eluting stents, thrombus aspiration, and by this, reducing sudden cardiac death, preserve LV function, and improve quality of life. So, mortality came down to 2% only, from 6 to 8%. If we look at the global perspective in Europe, 85% of patients with STMI are treated with primary PCI. And you see the breakdown, almost everywhere, primary PCI is superior to other therapy, including fibrinolysis. And reperfusion rate is also superior in PCI, primary PCI group to lytic group. Almost 95-97% reperfusion rate compared to fibrinolytic group. And in-hospital mortality also very low in primary PCI group, is around 4%. In Bangladesh, we started primary PCI in 1999, and it was done at NICBD by Dr. Mominuzzaman sir. After that, we need to know what we have. In Bangladesh now we have more than 1,000 cardiologists, 300 cardiac surgeons, hospital 103, and cardiac surgery facilities 29. And we have 5.7 cardiologists for 1 million population and 1.2 cardiac surgeon for 1 million population. And you see the global perspective, we are much more lag behind in this. Already we have almost 5,000 beds for cardiac patients, and other beds are increasing in numbers. We have already 64 cath labs in 41 centers. Remember, we have 64 districts. So we are approaching cardiac cath lab centers to every district very soon. These are the breakups. And you see the procedure-wise, we are increasing very rapidly. In 2018, we had 4,000 procedures, and in 2022, we have 30,000 procedures. So a number is increasing. And primary PCI is coming up comparing to lytic therapy in different centers of Bangladesh. So what are the facts and what are the myths? The myth is primary PCI is no better than thrombolysis. Let us see what happened. Already Professor Boren sir described very nicely. The primary PCI is the number one option, evidence-based procedure even within 48 hours. Now I have learned that it may be up to 72 hours. It is not for fibrinolysis therapy. We can fibrinolyze only 12 hours. So all of these already shown recommendation-wise. You see the death rate. The death rate, non-fatal MI, cardiac CVA, all combined parameters are much better in primary PCI group. So is out. The next myth is primary PCI is better but not much better. Let us see. Let us see the primary PCI associated with significantly lower 30-day mortality relative to fibrinolysis regardless of treatment delay. So it's out. Let us see pharmacoinvasive PCI is as good as primary PCI. Let us see. The ASCENT 4 30-day mortality is much more lower in primary PCI group. And its composite, stroke and other composite, it is also much less in primary group. So it's out. Now it's the third myth, too expensive. You see the meta-analysis and cost effectiveness is much more lower and better health outcome in primary PCI compared to thrombolysis. So it's out. So primary PCI saves myocardium, minimizes risk of arrhythmic death, minimizing risk of reinfarction, IRA reperfusion to further limit myocardial damage, and as a result, reduction of mortality and improvement of quality of life. So I can, no time, so I can show this is a pharmacoinvasive patient. So this is TIMI 1 flow, received tenecteplase, and we did the PCI, routine PCI after 1 day. So this is pharmacoinvasive arm. This is primary PCI. This is anomalous circumflex origin, LAD 100% proximal with thrombus, and we did direct stenting and TIMI 3 flow. So it's good. Primary PCI is better than any other option of treatment. It's obvious. So what's your opinion?